Good afternoon, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. Distinguished guests, Senator Warren, students, faculty, alumni, and friends, on behalf of our school, welcome to today's conversation, the final part of our three-part discussion on antiracism as health policy. These public health conversations are meant as spaces where the broader community can engage with the fundamental issues that shape our health. Over the last 2 days, we have discussed how political policy can help shape a society where racism no longer undermines health. As we begin the final session of the series, I would like to once more thank our co-host, the Boston University Center for Antiracist Research. Thank you, Professor Kendi, for your partnership on this event. Thank you to Senator Warren and Congresswoman Presley, and to all our speakers. And thank you, Meredith Brown and Alicia Noel, whose logistical work make these events possible. At our first session, we discussed data, race, and COVID-19. Next, we hosted a conversation about connecting research and policy. And today, we're going to end by discussing anti-racist policy solutions. We encourage you to follow along on social media. We will be live tweeting this event by our Twitter handle @BUSPH. And also note, we'll be posting video of all 3 sessions of this conversation on our website. To begin today's event, Senator Warren will sit down virtually for a conversation with Dr. Ibram Kendi, the director and founder of Boston University's Center for Antiracist Research. We will then proceed to a moderated discussion with our other speakers. Senator Warren has represented Massachusetts in Congress since being elected in 2012. Before that, she was a consumer advocate and the intellectual architect of the Consumer Financial Protection Bureau. Senator Warren was a law professor for more than 30 years, including nearly 20 years as the Leo Gottlieb Professor of Law at Harvard Law School. In 2020, she was an inspiring candidate for President of the United States. Senator Warren, Dr. Kendi, the floor is yours. Thank you for joining us.
Thank you, Dean Galea, and I've just been truly inspired, in many ways fed by this 3-part series, and thank you for your partnership and in working with my colleagues to put this together. And I've been looking forward to this conversation, Senator Warren, for quite some time, because in many ways you've been one of the leaders nationally in, first and foremost, sort of declaring and encouraging the nation and states and counties and cities to declare racism a public health crisis. And obviously it's hard for us to even begin to understand the solutions without understanding the problem and declaring it. And so why has it been so important for you, for the United States, to declare racism a public health crisis?
Well, thank you. Thank you for having me here today and for giving me a chance to talk more about this with you. I find your work on anti-racism inspires me and keeps me going. So let me start with this question about why we have to declare racism a public health crisis. Look, health inequities are nothing new. But what's happened is that COVID-19 has put us in a position where we can no longer ignore centuries of how structural racism has created deep disparities in health outcomes for Black and Brown communities. Long before COVID came along, the disparities in diabetes, asthma, hepatitis, hypertension, infant mortality, maternal mortality and morbidity, police brutality, all of these fell harder on African Americans. We see in the data the racial disparities, and it forces us to take a step back about why that would be so. And here's where we see the lack of access to medical care, a history of neglect and abuse by the medical system, discrimination, generations of structural racism that have made communities of color more vulnerable in a public health crisis like the COVID-19 crisis. So I think that it's just finally time for us to acknowledge the impact, the health impact of structural racism. And that means treat structural racism like we would treat any other public health problem or disease. That means invest in research, into its incidence, into symptoms, into causes, and finding ways to treat and to cure it. We know there is a public health impact of racism. It's time for us now to say that openly and begin to make real change.
Definitely, and you stated that the need to invest in research and also that if there's anything that the COVID-19 pandemic has shown us, that indeed structural racism is a problem. But there was a time around this time last year, specifically towards the end of March, that states and the nation didn't even know that COVID-19 was disproportionately infecting and killing, Black, Brown, and Indigenous people. And you, along with Congresswoman Presley, really led the way in calling for that racial demographic data. And so first, if you can just take us back to that moment, why was that so important for you to do that? And how did you have that foresight, in order to call for it?
So look, for me, it starts with a basic premise. You can't fix what you can't see.
Yeah.
If you won't look for a problem, you can't call it out, and then you can't make change. So how this started was, take you back to February and March of last year. And you may remember two things were going on. The first was how hard it was to get tests just to figure out who had COVID and what households it was showing up in, what communities it was showing up in. There was a real stretch to try to find those tests. And the second was the information we were getting out of the first test. And what was the information? It was the only two things that were being collected. And that was the age of the person who was being tested and the gender. And then, of course, the location where the testing was occurring. So that meant early on, we began to identify that older people were more vulnerable to COVID-19 and more likely to die if they contracted it. We could do that because the early data started showing us differences.
Yeah.
So I was talking with Ayanna, and we were talking about the fact that we know there are racial health disparities, like I was just talking about earlier, diabetes and hypertension, things that we're not doctors, Ayanna and I, but we hypothesized it might have something to do with whether or not you're likely to contract COVID, or if you contract COVID, whether or not you have higher mortality rate. So Ayanna and I were talking about this, but you can't tell if you don't have the data.
Yeah.
So that's where we started in on this, Dr. Kendi. Ayanna and I said we wanted to see the data. And we started by asking, and then asking louder, and then asking louder yet, for the CDC to start collecting and releasing the data on race. And of course, as you know, then the story starts to unfold that COVID-19 is a crisis that was not hitting all communities equally. But you can't know that if you don't have the data. And that's where this started.
Definitely. And so, yeah, literally it was this week last year that it became national news.
Yeah.
And so then from there, you and Congresswoman Presley and others started calling for and pushing policy solutions, to this crisis. And so can you share with some of those, with us some of those policy solutions?
Sure.
And importantly, why were those so critical to potentially solving this crisis, this public health crisis?
So let me say, though, on the data front, can I make one more pitch on
Sure,
data?
Sure, please.
And that is to say,
and this is right up my alley. So it's
I know, it's one of the things I love about you, Dr. Kendi. You are a data nerd. And I say that from the warmest place in my heart as a fellow data nerd. But
yes.
I want to add, because I think this is really, it helps inform the argument. The latest data I've seen, and maybe there's something more recent, but the latest I saw showed that we were collecting data on race, on age and on gender in about 98% of the COVID cases, and those data are largely publicly reported all around the country. But the data on race was only at about a 50% report level. That there's still enormous resistance to report in some places to reporting these data, to collecting these data and then reporting them publicly. I want to put in a plug here for our new HHS secretary, yes, Javier Becerra, who has committed that he is going to improve data collection on health disparities moving forward. And
Wow.
That's true both in COVID, but it's true overall. And I start there because I think this is a powerfully important starting place in dealing with the problem. Now,
And Senator Warren, if I can just intercede really quickly,
of course.
just so people can understand why, another reason why this is so critical. And I think you spoke about it earlier, that you can't solve anything you can't see. And so if people aren't identifying racially, which allow us to collect racial data, then how will we see racial disparities?
That's right.
And if we can't see racial disparities, how are we going to even identify the policies and practices that need to change? And so literally it'll be March all over again, where people are saying this is the great equalizer, coronavirus, when indeed behind the scenes it was not.
That's right. That is exactly right. And that's why it's so important for everybody to help with these data. And that means both self-reporting and holding officials accountable, that they make these data public. Because this is also our first vector for being able to get help to the hardest hit communities. You know, last week I was in Quincy, I was in Lynn, I was in Pittsfield, I was in Methuen. I saw firsthand the incredible work that these communities are doing to be able to try to vaccinate their populations, right? To get people in and vaccinate them. And the people who were there were so happy to be there. There were a lot of them were using volunteers, but they need more resources. They need more vaccines, right? And so part of the policy response that I've been focused on has been to push for funding for medically underserved communities. And we were able to get a big chunk of that, $1 billion, into the American Rescue Plan. And the basic idea behind it, in effect, is to say, I get it. A big part of public health is that money we put into drug companies and up high to make sure that we're building a public health infrastructure that reaches everyone. But some of those resources need to go in at the roots. You need to water down at the roots. And so this $1 billion is specifically designed to go straight into medically underserved communities and put that money on the ground, put that money in hiring local folks who can reach out to people, trusted neighbors, people who can help with vaccinations, with data collection, with reporting enhancement. The idea is to put lots of not just grants, but sub-grants out to nonprofit health organizations so that you've got more people who have a chance to be reached by our public health efforts. So it's a design that's kind of going in two places at once, but it was so important to me as we passed the American Rescue Plan to make sure that we got at least $1 billion down truly into the roots so that we could deal head on with this problem.
Wow. And even my wife, I think I've told you before, my wife is an ER doc, a pediatric ER doc. And most people, when they go to the emergency room, they don't like that they have to wait forever to be seen.
No kidding.
Can you imagine if we, as you stated, we invested in ensuring that we had a healthier population, that people had more preventative and primary care? What that would mean is medically underserved people would not be using emergency rooms for primary care. What that would mean is we would go and we would be seen faster, right? And there would be more providers for us. But And I think that's one thing I've learned, especially over the last year, about how much ensuring that the community is healthy is going to
Yeah.
ensure that we as individuals are healthy.
So let me ask you a question,
Mhm.
because you've got your own way of trying to get a lens into the health of communities and advancing and advocating for the health of communities. And that's through your COVID racial data tracker. So I've been all over your site. If you check the usage rates, you'll find me there. So talk a little bit about what you found, kind of why you put this together and what you've now found.
Well, I mean, as you stated, around this time last year, due to your efforts and the efforts of others, finally states started releasing, if they were collecting it, the racial demographics of people who were being infected and killed. But the CDC, but the federal government, there wasn't a sort of a national site that was collecting and regularly updating and tracking all of that data. So an individual had to go to different state sites or different county sites to figure out whether there was disparities, and sometimes those states did not even reveal them. And so because the federal government wasn't doing it, because the Trump administration wasn't doing it, we decided to partner with the COVID tracking project to build this COVID racial data tracker. And so we were able to assemble this army of volunteers who regularly was scraping this data and uploading it into this tracker, and to the point at which somebody could go to the tracker and see if there were racial disparities in Mississippi or Montana or Alaska or New York. And what we found is that indeed there were disparities, that specifically Black, Brown, and Indigenous people were being infected and killed at the highest rates throughout the entire pandemic. Black folks were dying at the highest rates from COVID-19. But as you also mentioned, there was serious limitations to the data because many states, they had a greater number, more racial data for deaths than infections.
Yeah.
And so even assessing something as a racial disparity was in some ways scientifically fraught when you only have 50%, of, let's say, the prospective, data set. And so it then demonstrated the need for more systemic data, or some states, different states would report out the data differently in terms of the racial categories. They would be different, which then forced us to have to create a streamlined process. So it was just a lot. But we created that data set because we felt it was important for people to know at any given moment where the disparities were and what those disparities were. And obviously, you continued on, specifically working on this issue, and ultimately introduced and reintroduced, I understand, in February, the Antiracism in Public Health Act. And so can you speak about that act in particular?
Absolutely. So I love this thing. Ayanna Pressley and Barbara Lee, Congresswoman from Mountain, California, and I put this together last summer. And the idea is to be a first step in anti-racist federal health policy. And the idea behind it is to study and address racial disparities in health outcomes. So this bill would create a National Center for Antiracism at the CDC and declare that racism is a public health crisis and conduct research, collect data, award grants to address the public health impacts of systemic racism, to combat racism in providing health care, and to evaluate the interventions that are intended to address systemic racism. I think of it this way. The federal government has made some modest efforts to address racial disparities in healthcare outcomes. But we need a big, bold step. We need big investments in developing the sense and practice of anti-racism. You just gave one perfect example. So long as we have to depend on 51 different public health state level systems, then we're going to have inconsistent ways that the data are reported. We're going to have some places that are committed to report the data and some that aren't. This is why there are some things that need to be done at the federal level, and the federal government needs to set up standards. If you want to be funded, this is what you have to meet. And then you stay after them. And because here's the thing, going back to that point you and I've talked about from the beginning, you can't fix what you can't see. There are people who know that and don't want information out there about what's going on. Just leave it where it is, and then we won't have to address this problem. That cannot be right. So the public health approach here is, let's treat this as we would any other public health threat. And it has one more aspect to it that I want to mention, and that is the bill also would require taking a public health approach to combating police brutality and violence by creating a dedicated law enforcement violence prevention program within the National Center for Injury Prevention at the CDC. As you know, the CDC currently does this on firearm violence and on intimate partner violence. We believe that there should also be within that dedicated group working on police brutality and police violence as it affects, particularly as it affects communities of color. So it's time for something big here. And part of the big that we want to do is, as I said at the beginning of this conversation, Dr. Kendi, I'm very much inspired by your work. And I think I called you when I first read that you would be opening the Center for Anti-Racist Research at Boston University. So can I ask you, while we've got an audience here to talk about it, can you say just a little bit more about the center and how it's going to help link up to the kind of changes we need to make?
I mean, as you know, Senator Warren, of course, you were in academia. I feel like you're still in academia in many ways, but there are so many incredible scholars who are doing incredible work and incredible research on different aspects of many different aspects of human life, but even specifically racism. But those scholars may not have been trained into how to translate that research for everyday people or even policymakers. They may not have been trained in terms of how to transform their research into policy recommendations for those who wants to not just know the problem, but solve it. And so in many ways, that's what we wanted to figure out a way to marry sort of scholarship and practitioners and really ensure that scholars are doing what they're doing best, but they have a route to policy change. They have a route to narrative shifts. They have a route to advocacy. So that's a very high level sort of, explanation. But I just wanted to really organize and empower, scholars. And in New England, no offense to any other part of the nation, we may have a larger concentration of scholars studying racism than anywhere, potentially even in the world. And so we're building a mechanism for these scholars to work with this center, to do what they do best. And finally, and I've actually been wanting to ask you this, before COVID, you were just an incredible champion, of ensuring, every single American had access to high quality healthcare, and certainly people of color as well, and certainly all those who were, medically underserved. And so now, on the other side of COVID, I guess it seemed as if you were fired up, about this before COVID. And so I'm just wondering how you feel about it all now. No, I was saying that, can you hear me now?
Now I can hear you. You just
sorry.
cut out for a minute there.
Sorry, I was saying before COVID, you were fired up to ensure every American had access to healthcare. And so I'm just wondering how you feel about that now.
So I see this as a moment of great opportunity. And the reason for that is because it's a moment in which we have had to face some hard realities in our nation, hard realities about racism, hard realities about our lack of preparation for a pandemic, for a real crisis. I see this as the deep injustices we face are not inevitable. They were created and facilitated through racist, hateful, bigoted policies. But that also means that we have a chance to change those policies. And I believe that for the first time in a very long time, we've got some wind at our backs on this. We've got more people engaged than ever before in looking at the question of access to healthcare, but also basic justice in this nation. And that we really have a chance to make big structural change. And that's what gets me up every morning. I'm convinced by what we can do. And the fact that you are drawing scholars together to help better inform policymakers. And I'm now a policymaker who wants to take everything you come up with and see how we can make our policies better. That gives me real hope. The kind of work you and I want to do wasn't done a long time ago, but now we have a chance to do it, to build out from it, and to build a stronger future, not just a future that says, oh, we don't want to be racist, but a future that's actually about anti-racism, that takes racism on head on and makes real change, says we can be anti-racist.
Definitely, we surely can. And I just want to thank you, Senator Warren. As always, it's a pleasure to be in conversation with you. And thank you, I think, potentially on behalf of many people listening, for your leadership, on this specific issue. Dean Galea.
Senator Warren, let me echo Dr. Kendi's thanks. Thank you for everything you do, everything you've done for a long time, everything you're going to be doing in the future, and for joining us today, for taking the time to be with us. Thank you again. And thank you, Dr. Kendi, for an outstanding conversation.
Of course.
It's now my great pleasure to turn the screen over to Dr. Regina Davis-Moss, the Associate Executive Director of the American Public Health Association, who will moderate the panel going forward. Dr. Davis-Moss.
Well, good afternoon. And if the host could enable my video, I'd love to see all the great faces out there. And while we're doing that, let me just say that I am really encouraged by that conversation. What a great way to talk about the importance of community-based, race-forward health promotion and disease prevention efforts. And as it's been clearly stated, racism is a driving force for the social determinants of health and equity. And it's a public health issue because, as Dr. Sandro Galea and his team have already framed for you, it affects large numbers of people, it threatens health over the long term, and it requires the adoption of large-scale solutions. Now, racism as a public health crisis has been in the forefront. We're hearing a lot about it, particularly with respects to states and municipalities. And I have to also give a plug because APHA has been tracking all of this. In fact, based on our tracking, since 2019, over 190 declarations have been adopted. So that's 8 states, 105 cities, 76 counties, and 1 board. And so during this panel, we're going to explore not only some of what that meant in terms of some of the legislation and the policies, solutions and practices that came out of that, but also some that might have been in place before, and what that's doing to help limit and shape opportunities for people of color. So we're going to be hearing from clinicians, research scientists, public health leaders, and decision makers about the actions we can take to advance racial equity and justice that are informed by data. And first, we're going to start with Dr. Consuelo Wilson. She is the director of the Engagement Core of the All of Us Research Program, a component of the Precision Medicine Initiative. Dr. Wilson oversees initiatives that meaningfully engage research participants in the governance, oversight, implementation, and dissemination of the program. She has pioneered methods for stakeholders engagement that involve community members and patients in all stages of biomedical and health research. And if you will just allow me, I would like to go ahead and introduce all the panels in the interest of time. After we hear from Dr. Wilson, we'll then turn to Dr. Dustin T. Duncan, who is the Associate Professor in the Department of Epidemiology at the Columbia University Mailman School of Public Health, where he directs the Spatial Epidemiology Lab and co-directs the Social and Spatial Epidemiology Unit. Dr. Duncan's intersectional research focuses on Black, gay, bisexual, and other sexual minority men and transgender women of color. We'll then hear from Dr. Torian Easterling, who serves as the first Deputy Commissioner and Chief Equity Officer at the New York City Department of Health and Mental Hygiene. Prior to serving as the first Deputy Commissioner, Dr. Easterling served as the Deputy Commissioner of the Center for Health Equity and Community Wellness at the New York City Department of Health and Mental Hygiene. There, he oversaw programmatic work focused on reducing overall premature mortality and closing the racial gap on the top leading causes of preventable death. And then finally, we'll close with Dr. Marshall Chen. And Dr. Chen is the Richard Perillo Family Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago and a general internist with extensive experience improving the care of vulnerable patients with chronic disease. I now give you Dr. Wilkins.
Thank you so much. I am not able to turn my video on, so Meredith, if you could help with that, I would appreciate it. Thank you so much. It's my pleasure to be here this afternoon. I'm really thrilled to be on a panel with such distinguished colleagues, and want to thank Dean Galea and Professor Kendi for organizing this series and having such foresight in what we need to do to really move the fields of health and medicine forward using anti-racist policies. So I'm going to be sharing about some of the work that we've done in my role as Vice President for Health Equity at Vanderbilt University Medical Center. And I really want to build on some of the ideas and strategies that have been put forward already over the last 2 days and have also been discussed by Senator Warren and Professor Kendi. So I think that, you know, this focus on data and making sure that we capture race, ethnicity data is obviously critical. We cannot begin to understand the inequities that exist without actually having these key demographics, but race and ethnicity alone are not the only things that we need. And we talk quite a bit about real data. So that is race, ethnicity, and language data, which is clearly something that we need, especially in the healthcare setting. But we also need to make sure that we're pulling in those social determinants of health, the information from the environment, things that we really need to have a clear picture of an individual's, of a population, of a group, of a community's health. And I think it's really critical that we also have some common data elements that are captured across the healthcare, public health, as well as social services sectors, and that there are processes in place for us to actually share that data. As part of our COVID-19 response at Vanderbilt University Medical Center, we put together a work stream that was dedicated to health equity so that we could really consider not in isolation, but as part of our COVID command center, how to actually disaggregate the data, the COVID-19 data, and identify problems and then come up with solutions. So this is from a paper resulting from that work that's just out earlier this year. And I want to point out a couple of things in particular. So as we began to disaggregate the data, again, by race, ethnicity, and language, some of the mistakes, or I think some of the issues that we have across the board with, obviously the missing data is a problem, but we also tend to erase communities. So when you look at a lot of the reports, because there are so few people who are American Indian or Native American or Indigenous, those groups are often left off. We also don't capture the other, and the other is very important. Just because people haven't identified themselves in these traditional ways that we, or the census, the government, the political ways that we have come up with categorizing people by race, just because people don't identify themselves in that way, doesn't mean that we shouldn't look at their outcomes, because otherwise we don't really know what's happening with them. And we also make sure that we still report the outcomes for people for whom we don't know their race or ethnicity. So when you look at this slide, at this data in the far right corner, we look at the rates within each of these groups, you can see that people whose race or ethnicity we don't know have the highest positivity rates for COVID-19. Similarly, when we looked at language data, we are also careful to include population level data. So what's our comparison of the nearly 2 million people in Nashville metropolitan area? What are the demographics there? And how does that compare to what we're seeing in positive number of people tested? So we've now tested nearly 200,000 people in-house at Vanderbilt for COVID, for the coronavirus, and have nearly 25,000 of those tests be positive. So when we looked initially, we found the most striking disparities were actually occurring among people for whom English was not their primary or preferred language. And in particular, we saw very early on that people who spoke Arabic and Nepali had the highest rates. And particularly for the community of people who spoke Nepali, it's a relatively small group of people, but you can see here, 32% of those people were positive. So then we began to bring in this social determinants data, and we started to look by zip code, and the darkest, the reddest area here, or magenta here, we identified the zip code with the highest number of cases. And what we found out about that zip code, well, things we already knew. People who lived in this zip code were actually more likely to be Black, but also more likely to be foreign-born, new Americans, immigrants. A third of them spoke languages other than English. They had higher household density. They actually were more likely to be working, but had a lower income. So all of these point to things that we now know as far as essential workers, and how do we actually gather that information, use it, and share it with others? Because early on, we realized that our health departments actually were not collecting language data. So we were able to tell them early on, hey, listen, I know you already know that in this zip code in Antioch, this is the highest, there's the highest number of cases here, but before you hire all of the contact tracers, you need to make sure you know that these are people who speak languages other than English, in particular Arabic. So we also need to make sure that we are investing in these community-driven solutions. So finding trusted organization, leveraging assets in the community. So often we actually talk about communities as if they're just deficits and deprived, and we don't actually appreciate the assets in the communities. And we need to appropriately fund the community health centers and other healthcare providers who are already caring for these populations. Early on, we partnered with community organizations who are in these zip codes. So we use that data to inform our strategies and solutions and identify ways to support these community organizations. And then our Nashville Metro Public Health Department worked with Siloam Health, which is one of our faith-based community health centers, to actually fund community health workers to do the work of not just contact tracing, but finding out what these communities needed, which was food. They needed financial assistance. They needed to be connected to healthcare. They needed assistance with things like thermometers. But unfortunately, we don't have systems in place right now. We don't have policies that actually allow us to charge for and be reimbursed for community health workers who have been really invaluable in many ways to our COVID response. And of course, in our response in other chronic conditions like diabetes and heart disease and hypertension. And finally, I think we really need to have solutions that are preparing us to address the long-term impacts of COVID. And specifically speaking about health, obviously there are going to be many other long-term impacts of COVID, but we need to make sure that healthcare is available for free. You know, we've been emphasizing the vaccine is free, but what about the long-term impacts and monitoring of people who are having symptoms like short-term memory loss, shortness of breath, and all of those things? We need to fund research to understand these long-term physical and mental health impacts of COVID-19. And we also need to appropriately fund, you know, the research that Professor Kendi has been talking about the structural racism and its impact on health. And many of you have seen this RFA from the NIH. And I just want to say that I'm really excited to see this, but yet again, we're not having enough dollars invested in this kind of research, and the institutes at NIH with the smallest budgets, NIMHD, NINR, so Minority Health and Health Disparities, and nursing are actually investing more of their total budget into structural racism than the Cancer Institute, NHLBI, all of these institutes with many billions of dollars in research funds are only committing to 1 or 2 awards on structural racism, and we will not address this problem without that funding. Thank you.
Thank you, Dr. Wilkins. We will now hear from Dr. Dustin Duncan.
Thank you very much. I'm going to share my slides. Okay. Sorry, just give me one moment. So today I'm going to talk about disparities in COVID-19 and provide a different perspective thinking about intersectionality. So Senator Elizabeth Warren said, if you can't fix it, you can't fix what you can't see. And I frequently say the following quote, which is really similar in some of my measurement course on spatial epidemiology. If you can't measure it, it doesn't exist. So COVID-19 has impacted us all in different ways. Perhaps you are quarantining at home and working from home. Perhaps you're a frontline worker and you're working, but the nature of your work has changed, whereby you're wearing PPE. Perhaps you know friends or family members who have tested positive for COVID. Maybe they've tested positive and they've survived COVID, but they now deal with the negative sequelae of COVID, including perhaps neurological outcomes. Perhaps you've had family members who have died. This is one example of one of my family members who died from COVID last year, my uncle. We know that there are significant health and social inequalities in the United States and broadly around the globe. Briefly, one of the striking disparities that I still find fascinating is the disparity in Black women being more than double, having more than double the rate of maternal mortality rate compared to white women. We know that disparity is long-standing, but we also know that there's an intersection there of education. We know, for example, that Black women who are most educated still have higher rates of maternal mortality than white women who are least educated. Of course, there are disparities in COVID. When it comes to COVID, these are the latest data as of today, but there are almost 31 million cases of COVID in the United States with over 550,000 deaths. There's been a lot of research and accumulated research that shows that there are racial disparities in COVID, not surprisingly. It really mirrors the existing disparities that we see in our society. For example, we see disparities in cases or infection, hospitalization, as well as deaths. We also see disparities in vaccine rollout. As an example, this is one report that showed that Black Americans are 4.2 times more likely to be hospitalized with COVID. There's been some emerging work looking at sexual orientation disparities in COVID, which shows that, for example, sexual minorities are more likely to have risk factors for COVID and more likely to acquire COVID, albeit the research is very sparse. I'm going to talk about intersectionality, why it matters, and what we should do about it. Intersectionality, coined by Kimberly Crenshaw, really suggests that there are various structural identities, gender, race, class, etc., that interact to produce different expressions of privilege and power. This is an example of a young Black guy who's wearing a mask that looks to be symbolize his Blackness and his queerness. And so there's a shirt that says Black Queer Lives Matter, and it highlights again the intersection of race and the intersection of sexual orientation. Here's a quote from Lisa Boleg, who's a well-known intersectionality scholar. And a participant, 37-year-old Nigel, in her study said the following: "Well, it's hard for me to separate my identities. When I'm thinking of me, I'm thinking of all of them as me. Like once you've blended the cake, you can't take back the parts to the main ingredients. I'm a gay man. Also, there's something to say about aspects of being a Black man." So how does this relate to COVID-19? So this is some theoretical work that we've done to highlight that Black men have sex with men, as well as transgender women of color, may be at increased risk for COVID-19. We know that 1 in 2 Black men at MSM will contract HIV in their lifetimes. And AIDS is one underlying condition that puts someone at higher risk for contracting COVID-19. We know that social distancing and social isolation may be difficult for certain populations, including Black MSM, who often have high rates of housing instability and may engage in in-person sex work due to job loss in the era of COVID-19. We know that many Black MSM, as well as transgender women of color, have low-income jobs that require frequent contact with the public, for example, transportation and service food industry. And of course, we know that these jobs have less economic safety that will allow them to have temporary leave from these jobs. Similarly, we know that there are high rates of HIV among transgender women of color. For example, it's estimated that 44% of Black transgender women are living with HIV. We also know that in-person sex work is quite common among transgender women, especially transgender women of color. So I'm going to talk about some of the studies that we're doing to address this gap. One of our cohorts is the N2 study, which is funded by R01 and the U01, a U01 from the CDC. About last year, from April to July, we conducted the N2 COVID study in Chicago, where we sampled about 226 Black men with men and Black transgender women. We had many goals, but to characterize substance use, HIV risk behaviors, COVID symptomology, testing patterns, thinking about how contextual influences related to these outcomes, including COVID symptomology. We assessed many things: PrEP, ART adherence, recent sexual activity, intimate partner violence, of course, many aspects of COVID-19, including COVID conspiracy theories. There are many, many findings from our work. I'll just share some of them with you today. One thing we found is that there was high rates of cannabis use, 71% in the past 14 days. We also saw that about 20% of our sample reported less sleep, and about 20% of our sample reported intimate partner violence. And I can say that all of these numbers are higher than our pre-COVID data show. We found that there are many correlates of poor health outcomes in the peak of the pandemic among our participants, again, who are Black men and sex with men and Black transgender women. For example, we found that intimate partner violence, as well as having financial burden from travel, were associated with greater perceived difficulty in assessing ART adherence. We also found that multi-level COVID-related stressors related to poor sleep. For example, we found that not having enough medication, knowing someone who's diagnosed with COVID, partner violence, and housing instability were associated with poor sleep health in the pandemic. So I want to highlight, yes, there's important for anti-racism research, but I want to highlight the importance of intersectional anti-racism research and practice. There's certainly a need for new and updated data. The data I'm presenting is rather small. It doesn't allow for any meaningful subgroup analyses. There's a need for robust data in these type of samples. And there's also a need for targeted health policy solutions. And just I want to end again to say that If you can't measure it, it doesn't exist. And certainly there's need for more measurement. Thank you.
Thank you so much for that very rich presentation, Dr. Duncan. We'll now hear from Dr. Torian Easterling.
Good afternoon. It is such a pleasure to be joining you all this afternoon, joining Boston University. Dr. Davis Moss, certainly it was really enlightening, insightful to hear from Professor Kendi and Senator Warren. And certainly my remarks do not stray too far from their conversation, and certainly be joining this esteemed panel. Really, I think the important points that I just wanted to highlight, really putting into practice some of the points that have already been elevated, and really talking about how do we really use a shared analysis, normalize anti-racism practice in public health, making sure that we are having a conversation together. Looks like I'm having a little technical difficulties. Here we go. So I think it's really important to state the moment that we're in. New York City was the epicenter of the COVID-19 pandemic, certainly early on, but I do not want to miss the point that we are still in a pandemic, and we're in a second wave. And we're seeing high number of variants that represent the majority of our cases. And so, one, I think it's important to just state that we are not, should not be surprised by the disparities, the inequities that are reflected in our COVID data. And, I'm pointing to one practice and policy that existed in the 1930s, speaking to redlining, but also understanding that there are so many other practice and policies, racist practices and policies that have led to why we are seeing these inequities, and certainly segregation, both thinking about neighborhood, but also thinking about healthcare access, certainly leading to why we're seeing a lot of the racialized outcomes. And so as we're thinking about an anti-racist public health practice, certainly finding those solutions are necessary. Very early on, even releasing the data, we recognize the missingness. You've already heard from previous speakers about unknown and the missingness in demographic data not being reflected. And really, it limited our ability to be able to direct resources and inform our roadmap to the operations that we were looking to undertake to respond to this pandemic. And I think it is really important that we continue to ground ourselves in how our infrastructure, both within public health systems, healthcare systems as well, but also resourcing our community-based organizations in a way that they're capturing data, that they are utilizing information that is being shared by institutions so that they are able to also redirect their resources in an intentional way. One of the things that we led with in New York City was a place-based approach, really thinking about ways in which we can tailor our resources. Many may know that New York City has one of the largest and robust testing operations that allow for individuals to get tests across the city. But it was very clear that we needed to have more place-based and race-explicit approaches in order to engage neighborhoods, engage community residents. And it wasn't just about access. It was also trying to rebuild and restore trust. Very early on during the pandemic, communities felt deserted. And I think we have to understand that equity isn't about all of the resources that we can garner and marshal into the communities. It's really also about doing the necessary groundwork, being authentic and transparent, in rebuilding trust in communities. And I think that part of our work was identifying the partners, the organizations, the institutions that were willing to show up in a different way. And so certainly working with our testing resources and bringing those into the community, but also figuring out how we're working within the environment that residents are interacting on a daily basis. So thinking about the bodegas, the supermarkets, making sure that these institutions also have signage and posters and decals, but also working with residents and hearing specific concerns and issues. And as we built this process out, it really allowed us to tailor the type of strategies and activities that would be really important on the ground. And so it was not a one size fits all. And certainly we had and built out a really robust testing strategy, but certainly making sure that these practices really reflected what the community was looking for. And this was really based on the data that we already began to really work on to really make sure that we were directing our resources in a really intentional way. And also sort of thinking about what are the other factors outside of just testing that really can support our core prevention strategies. You continue to hear, how are we encouraging people to wear masks? How are we encouraging people to limit their interactions? And so really thinking about how do you really support a community to do those core prevention strategies is not enough just about messaging. And certainly the message is important. The messenger is also really important, but it's also really figuring out how we can do that in a way that really applies in a real life situation. And so those are the type of partnerships that become really important and really thinking about how we can successfully drive down cases and percent positivity. And we certainly saw the benefit of doing our place-based work. And so we're certainly not surprised seeing the disparities now in our vaccine rollout. And I think, certainly keeping equity front and center in our work, we continue to see even now persistent disparities, even as we roll out our vaccine. So on the left-hand side, you are looking at a map of where we are already seeing uptake in neighborhoods for New York City. And certainly when you sort of reflect back to my first slide, even for the redlining map and for the map with the percent positivity, certainly the neighborhoods that had high percent positivity, neighborhoods that have been redlined are certainly not in the same neighborhoods where we are seeing high uptake. And so, the city took an approach to really lay out an equity strategy, a vaccine equity strategy, building off of our equity action plan for our COVID-19 response. And so we knew very early on, really thinking about the ways in which we were going to shift our investments so that we can really support communities and really thinking about communities of color and low-income communities that were hardest hit by COVID-19. And so the language that you're seeing at the bottom of the slide is actually our opening statement, really understanding that we have to acknowledge the historical and the current injustices that are happening, and how even city government has played a part in that. And starting with that, I think that allows us to not only build trust in the vaccine, but also build trustworthiness. And I think we cannot minimize how important it is that we need to build trustworthiness back in our communities, in institutions, in government, in order to achieve the outcomes that we're looking for. And I think that those are ways in which we can be intentional. The other ways in which we're being intentional with our vaccine rollout, really looking at our data in a way that allows us to really prioritize populations in communities that have been hardest hit. And so building off of the CDC's social vulnerability index, we expanded the index looking at 5 equity domains. One, the COVID-19 wave 1 data, And so we can certainly see where we saw high death rates in specific neighborhoods. Also looking at health status, as we know, there were specific underlying chronic conditions that led to severe illness and death due to COVID-19. Social inequities, so looking at concentration of poverty and other outcomes, living status, and also occupation. And so things such as frontline essential workers, or even thinking about multi-generational homes. And so that really allowed us to identify the neighborhoods. And again, a place-based strategy, but I think to take it a step further, really thinking about how are we also being race explicit. And I think if we're going to think about an anti-racist public health practice, certainly having place-based, but also thinking about race explicit strategies are really important as well. And so we framed our equity strategy in these four buckets, thinking about access and how we're really thinking about our allocation strategy to move doses into neighborhoods to ensure that there was more sufficient uptake within communities that have been disproportionately impacted. And as you've already heard, how important it is to really invest in community-based organizations that can serve as clear messengers, factual information, sharing that with community, but also thinking about ways that you can really build rapport and connect people to appointments. And so really investing in community-based organizations. And many of these community-based organizations, we have been working with them to build capacity around our contact tracing, and then they evolved into working with us on our vaccine outreach and engagement that really also allowed them to schedule appointments within neighborhoods that have been disproportionately impacted. Our outcomes not only tell us where we need to go, but also certainly allows us to build out a roadmap because this is going to be work. If we're really thinking and invested in dismantling structural racism, really understanding where those gaps are. And so you've already heard about missingness in data and understanding how providers are not ready to always report. And so we saw very early on that there were many providers that were not reporting race and ethnicity. And so clearly outlining a strategy that we were able to really influence our providers to report race and ethnicity. And so we actually saw saw a decrease in a number of providers that were not reporting race and ethnicity. When we first began our vaccine outreach strategy, there were over 40% of providers that were, reports that were reporting unknown in our race and ethnicity. We, due to our work, we've actually gotten that down to 11% in really moving more towards the single digits. And so this is the type of work that we're continuing to push to ensure that providers who are vaccinating New Yorkers are reporting out on race and ethnicity. And I think these are the ways in which we can look at our structures and systems that can really support an anti-racist framing. And that's what we need to continue to push forward with. And so just to end, because I think it really is important to, again, to just state how we must think about how we're capturing data so that it can inform our anti-racist practice. Normalizing how we think about this and having shared language really allows us to organize better and then operationalize a strategy in sort of building out our anti-racist practice at the New York City Department of Health. Has been the work that we've been doing since 2016 to both do an internal transformation, really looking at the ways that our organization can become an anti-racist institution, doing trainings, but also thinking about how we're embedding equity into our overall operations. And so that must include our research agenda, our policy agenda, in the ways in which we invest our funds as well. Last year, our former commissioner has declared racism as a public health crisis. And so doing the next step of really making sure that there are actionable objectives that are tied to that declaration. And I think that is the work that we all must do. That is not just symbolic, but really thinking about some concrete actions. And lastly, I think more so thinking about how we're doing more investments in our communities, particularly those communities that not just have been hardest hit by COVID-19, but have experienced long-standing disinvestment. that continue to experience longstanding health inequities, thinking about the ways in which we can leverage federal funding, state funding, but really invest in the community partners that have been doing the critical work to achieve health equity. Thank you.
Thank you so much, Dr. Easterling. There were so many important nuggets in that presentation, but I think one that stood out for me was how you highlighted that we actually can collect the data. We often hear that patients don't want to provide the information, but I think you've demonstrated that we can actually implement strategies that allow us to do so. Our last presentation will be from Dr. Marshall Chin, and then we'll take questions from our audience.
Thanks very much, Dr. Davis-Moss. Do you see my title slide on the screen now?
Yes, we do.
Okay, great. So I'm going to speak about racism against Asian Americans, which is too often an overlooked and invisible racial ethnic minority group, and then discuss incorporating anti-racism into care delivery and payment reform. Not advancing, right?
It is not. If you could launch it as a show, it's showing your slides.
Okay.
Either that or you can just click the slides on the left.
Okay. How's it? Title slide now in slideshow
Yes.
format? Okay,
Perfect.
great.
Yes.
Thank you. And so when I was a kid growing up in the Boston area, we would go to Boston's Chinatown every Saturday to visit my grandparents and the extended family. And I learned from my aunts and uncles the story of discrimination against Asian Americans, of how we were viewed as the perpetual foreigner, the other, and the scapegoat for whenever there was an American recession. It's a trading card from the 19th century. The Chinese must go. We also learned the story of the incarceration of Japanese Americans in concentration camps by the American government during World War II. Japanese Americans were thought to be a group that this could be done to by the American government. And the violence against Asian Americans, this is long-standing. 19th century, there were lynchings of Chinese Americans. 1982, this is the story of Vincent Shin, who was murdered by two white auto workers in Michigan who thought that he was Japanese, and again, scapegoat for American woes. The two white workers were convicted of manslaughter, told to pay a $3,000 fine, and given 3 years of probation. So we know that the law viewed the value of a Chinese American life at $3,000. And last year and past 4 years, you have President Trump constantly saying the Chinese virus, the Kung flu virus, and again, not enough national outcry of saying this is unacceptable. And then we have Atlanta. This is this week's cover issue of Time magazine. When it came out, my wife, who's Japanese, was very excited and said, "You have to read this story." And within the story, one of the writers, Lucy Feldman, who's an Asian American, works at Time, she was telling the story, and she titled this, "A Love Letter to Asian Americans. We are always waiting our turn to be important." And she was telling the story of what she had told the Time editors, what story she wanted in Time about the Atlanta shootings. And she said, "I told them what I wanted, a piece that says the thing I would want to read, a piece that tells me, as an Asian American person who has deferred and cared and tried so hard to help, that I am worthy of the same, that we are worthy, you are worthy." My wife, this resonated so much with her. It's an important, powerful message with myself also. Dr. Duncan told about how important intersectionality is. And if you think of most of the people who were shot in Atlanta, these were Asian American women, low income, particularly high risk. If you haven't seen it already, I'd highly recommend this Korean American movie, Minari. It tells the story of a Korean American immigrant family in Arkansas, poor. So again, intersectional issues, high risk populations. My wife and I saw this live when Anderson Cooper was interviewing Jeremy Lin, the basketball player. And one of the points that Jeremy Lin made about the hate crimes against Asian Americans is that some of the older generations of Asian Americans would tend to be silent, whether they were shy or differential or ashamed of what had happened to them. Whereas the younger generation, there was more of a movement of speaking up. And I do hope this continues of not only Asian Americans speaking up, but this is truly an area where allies are critical of lending voice and making sure that Asian Americans are not an invisible minority. I'm going to turn now to solutions and the idea of having an equity lens when we think about payment reform and care transformation. I co-direct a Robert Wood Johnson Foundation program called Advancing Health Equity, Leading Care, Payment, and Systems Transformation. And what we're doing is bringing together payers. So this is like the state Medicaid agencies. These are health insurance plans, Medicaid managed organizations, then the frontline delivery organizations, the clinical providers, the hospitals and clinics that provide care. And the idea is that too often we've been siloed, and that really every individual stakeholder can only do so much unless it all aligns. We're striving for payment reform that supports and incentivizes the care transformation that can advance health equity. Back in December, I wrote an editorial that tried to summarize very concisely what we know about advancing health equity in the healthcare sector. And this is a slide that tries to capsulize it in one slide. So you see at the very top that ultimately it's critical that we all have a mission to improve advancing health equity, that too often there's lip service in terms of lofty language, but then the follow doesn't happen, or we really don't truly prioritize health equity as a nation. And the second is going to be the intentionality about advancing health equity. Too often groups do a generic type of quality improvement intervention or a generic payment reform that is not really specifically designed to reduce the disparities we see by race, ethnicity, or socioeconomic status, or sexual orientation, gender identity. You see, we then divide into two different areas. On the right, you have a so-called roadmap to reduce disparities. My colleagues have talked about the importance of collecting data such as race, ethnicity, and then stratifying performance data like clinical outcome data by these social strata. So identifying the disparities, doing a root cause analysis, in particular, talking with the affected patient communities to understand why these disparities exist, and then specifically designing and implementing our interventions to address these underlying barriers and causes of disparities. Dr. Easterling's recent talk about place highlighted some of those different points, as did Dr. Wilkins. On the left, you see the creating a culture of equity. I think a lot of organizations are struggling with this. Longstanding, there's been an effort to try to understand individual and personal biases, implicit biases. What does it mean, though, to search out and root out the structural biases within organizations that bias against and oppress marginalized populations? And probably just about every, if not all, organizations have this embedded within what we do. On the far right, you see the role of payment and social determinants. So again, it's payment reform, not for payment reform's sake, but payment design that specifically supports and incentivizes the care transformations that advance health equity. And then we've heard a number of the speakers talk about basically addressing social terms of health and really addressing both the medical and social drivers of health and cross-sectoral partnerships between healthcare and social sectors. It's both the drivers for an individual patient. So like I'm on the ward service right now, and we can basically think about how do we identify our homeless patients and help that individual homeless patients. And then structurally, how do we partner with the community organizations and social service agencies to address the problem of homelessness in the city of Chicago, ultimately improving population health, improving health equity. Back in December, my colleagues, Monica Peak, Monica Vela, and I, we have a paper in academic medicine that's entitled Practical Lessons for Teaching About Race and Racism, 12 practical lessons. I'm just going to highlight two. You see in the upper right quartile, this is one of the parts that says, start with stories, not numbers. And I've been sort of going through Dr. Kennedy's book again, and one of the brilliant parts of his books is how he starts each chapter with his own personal story, his own personal narrative, because he understands the power of that personal story, and then going into the structural answers. And sometimes if we start off just with numbers, it almost becomes a signal to our audience that they can tune out, as opposed to if we start with the personal stories, so powerful, so impactful. See the bottom right quartile, the last point there about teaching about solutions and how to be a leader, how to be an advocate. We found that it can be actually demoralizing to trainees if we have talks about equity and disparities without talking about solutions, without talking to be an advocate. And so really the focus of today's session. I'll end with this slide that one of my hobbies is I do improv and stand-up comedy. And as stand-up comedians, we're taught to read the room. So in other words, to size up the audience, because if we don't, we're gonna basically be killed off stage. And so it's both thinking about our impressions of the audience, but also the audience's implicit biases of me. So when I walk on stage as an older Chinese American man, what biases and impressions do the audience have on us? And in some ways, the dialogue we're talking about in this overall great series that the BU has organized really is that dialogue to have the free, frank, fearless discussions about structural racism, social privilege, white privilege, colonialism. And then also, one of the powers of stand-up is to basically point out the absurdity of racism, really as a step forward to talking about structural, systemic policy solutions. Thank you very much.
Thank you so much, Dr. Chen. We have, such great questions in our Q&A feature, and we're not going to get to all of them, but I'm going to do my best to try to ask these questions based on the themes. And given the limited amount of time, I probably will only be able to pose a question to each presenter. So I'll start with Dr. Chen. And the question is related to the providers and the payers. And if you could give an example of how you're working with them to advance racial equity, or advance health equity, and also an example of a payment reform. And if you could do that in a minute and a half, that'd be great.
Okay. So one example is that we recently had a meeting with the senior leadership of one of the Western states' state Medicaid programs. The whole idea is, what does it mean to have an equity lens in payment? What does it mean to look for structural racism within the programs? And so the feedback we got was that many different parts of the organization really hadn't thought about before. So it doesn't matter if you're in payment, or if you're in quality, or if you're in human relations, or if you're in finance, or you're the data analysis. There's a role for everyone in terms of advancing health equity. And so the idea is, like, how do we get people to understand in their daily frontline jobs, what does it mean to implement equity in their work? And so that was like one example, and we're hopeful that that state Medicaid agency will trickle them through the organization into ultimately the payment policies. Another example is the state of Oregon. They have a broader type of payment flexibility than most states, where, for example, a patient with asthma, where if they don't have an air conditioner in the summer, that can lead to hospitalizations, emergency room visits. They're allowed by the Medicaid program to pay for air conditioners for their patients with asthma. So it's a forward-seeking way of thinking about creatively, how do you address both the medical and social factors that lead to better outcomes for patients?
Thanks so much. Dr. Easterling, we got a couple of questions about the specific strategies you use to help decrease that number from 11%. To 11% with regard to getting the doctors to report that data. So if we could talk about that in a couple of minutes, please.
Yeah, certainly. And I thank you for the question. I think it's really important of doing some type of analysis to see who the providers are who are vaccinating and what type of support. And so very early on, we had a limited number of providers who were already vaccinating, and we were able to do some direct engagement with those providers. Do our provider engagement, we also provided guidance to organizations, why it is important to collect race and ethnicity. From the at the beginning of the guidance, I think it's really important to just underscore that this is helping us eliminate structural racism. And I think it's being clear and direct to organizations and to providers about how, even with their silence and their inaction, they can perpetuate structural racism. And I don't think we're always being authentic and clear with organizations about why this is important. But the capacity building is just as important. We cannot expect that all organizations understand why it is important and how they can take the necessary steps, making sure that they can report race and ethnicity. I'll just say one last point. And you heard earlier during the discussion with Senator Warren and Professor Kendi, and then you also saw it again with Dr. Wilkins, really making sure that we're grounding this in what the limitations are. We're only capturing only a few categories and thinking about race and ethnicity and providing guidance to understand next steps of really being able to capture more ethnic backgrounds and how their providers can really do that. I think it's also important as well.
Thank you. Great points. Dr. Duncan, this question is related to your quote, and it's, by the time we can see the disparities, have we already missed the opportunity to practice prevention, the best practices for prevention?
Certainly is a very good question. I'll say it this way. I think that one, it's important that we are thoughtful and intentional about measurement. To Senator Warren's point, if we don't have it, we don't know that the disparity exists. And secondly, I think that when we start to have a sense of that a disparity exists, even when it's theoretical, I do think it's, including in the times of COVID, it is important for us to begin to take some action. So for example, we hypothesized that our sample, or that Black sexual minority men and transgender women of color would be at increased risk for COVID acquisition and can have negative consequences, and our data is showing that. And so as we were developing our survey, we were already thinking about how do we build the infrastructure to actually help our participants in this case become clients in our services. So how do we think about rollout services? So for example, we made sure to have participants give them opportunities for getting COVID tested, give them opportunities for social services, recognizing that we anticipated these to be issues. So I'm not sure I totally answered the question, but.
Yes, you did.
Okay.
Thanks. And Dr. Wilkins, you spoke a lot about populations with English as not as their first language. So the question is related to what are some best practices that you would recommend with regard to how do we really reach this population beyond pamphlets that have been translated to the language? How do we inform them? How do we, what are some lessons learned?
Yeah, we talk a lot about having people who are bilingual or multilingual as interpreters. And I think it's important to emphasize bilingual and bicultural. And so we really need to engage people who understand the culture of the populations that we're trying to reach and are part of their communities. And so a lot of that we do through these trusted community organizations. I mean, we're hearing a lot about community organizations, but we really rely on them as the people who know the communities, who know where folks live, work, play, pray, what their concerns are, what are going to be the barriers and challenges to uptake. And from a policy standpoint, these are the organizations that we need to find ways to fund. We're not funding them. They've been, ravaged by the pandemic and needing to provide more resources. And we've made it incredibly difficult for them to even apply for funds or get easy access to funds. And I think that's something we need to invest in.
Excellent. I think that's a great way to close. Thank you again to Dr. Chen, Dr. Easterling, Dr. Duncan, and Dr. Wilkins. I now give you back to Dr. Sandra Galea.
Well, first of all, thank you very much to this panel. Thank you, Dr. Davis-Moss, for excellent facilitation. Thank you, Dr. Chen, Duncan, Wilkins, and Easterling. I thought it was a terrific day. I would like to end the three-part symposium with a few thank yous, if I may. So first of all, I would like to thank all our speakers and panelists today and the past couple of days. We sort of lean on the adage of we ask good people to do more, and we've sort of asked some great people for this event, recognizing that you're all busy. So really, from the bottom of our hearts, thank you for being a part of this symposium. Secondly, a thank you to Dr. Kendi, who has been the intellectual partner throughout these 3 days of events. And I think he had to roll off today because he had something else. But I want to say thank you to Dr. Kendi formally for his partnership on this event. I want to thank the folks at the Antiracism Center, in particular, Professors Monica Wang and Elaine Sosi, who are both faculty at the School of Public Health, but also faculty at the Antiracism Center, and the staff of the COVID Racial Data Tracker, particularly Rachel Lee and Aviva Schwartz, who were partners in setting this up. I want to thank the team at the School of Public Health, in particular our Dean's Office team, Catherine Edmond, Meredith Brown, Alicia Noel, and our communications team, in particular Michael Saunders. And finally, but last but not least, I actually want to thank all the participants. We have had, so people know, about 5,500 people participating in these 3 days of the symposium. And it really has been the most dynamic and engaged conversation from participants of any event I've ever been a part of. It really, I think, speaks to quote Dr. Kendi, how dear this issue is to so many of us at this moment in time. And so I want to thank all the participants for giving us part of their time, being a part of this conversation, and perhaps more importantly, for everything everybody is doing to create a healthier, better, anti-racist world today. So I just want to say thank you. Thank you to everybody in the audience. Thank you for being a part of it. And thank you to everybody for their work every day.